So, hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sakia. Today, I'm joined by Dr. Neal Shore, Medical Director at Carolina Urologic Research Center in Myrtle Beach, South Carolina, in the US of A. It's a lovely part of the world I recommend visiting. Additionally, he serves as Chief Medical Officer of Surgical Oncology and Urology at GenesisCare USA. Neal graduated with a Bachelor of Science in Public Policy Sciences and a Doctor of Medicine from Duke University Medical School, also in the Carolinas, and a very fine institution. He completed his general surgery and urology residency at New York Hospital-Cornell Medical Center, as well as the Memorial Sloan Kettering Cancer Center in New York City, which I'm sure everyone knows about. He's an internationally recognized expert and researcher in systemic therapies and treatments for urologic cancers, with advanced urologic cancers, including, of course, prostate, kidney, and bladder. He's conducted, wait for it, and there should be a drum roll, more than 400 clinical trials focusing mainly on genitourinary oncology, and has authored or co-authored more than 350 peer-reviewed publications and numerous book chapters. You know, I thought I'd been busy, but I'm a sloth in comparison. He serves on the Society for Immunotherapy of Cancer Guidelines Committee for bladder cancer, as well as the boards of the Bladder Cancer Advisory Network, the Maple Tree Alliance, the Duke Global Health Institute, and he's the chair of both the Prostate Cancer Academy and the Bladder Kidney Cancer Center Academy for the large Urology Group Practice Association Specialty Network. He also co-chairs the annual American Urological Association International Prostate Forum. And I know he's a go-to guy on all these topics, and we've got lots and lots to discuss. Beyond his commitment to advancing the fields of urology and oncology, Neal says, and I found this fascinating because I'm really very interested in what a friend of mine calls their emotional source code, says that he's always inspired by kindness, beauty, and truth. Would that our politicians had the same kind of inspiration. Welcome to the podcast, Dr. Neal Shore. Real pleasure to have you here.
Dr. Sakia, it's a great honor to speak with you. Thank you very much for the invitation.
Well, you're going to have to call me Jonathan, or there's going to be lots of doctor this, doctor that, flying backwards and forwards. So, Neal, your career in urology and oncology specifically has been extensive and extremely impressive. Can you give us what initially drew you to specialize in urologic cancers? What motivates you to continue pushing the boundaries in this field? And, you know, for men, we're pretty lousy at being our own advocates. And, you know, to see someone who's been as active as you are is actually very refreshing. So have at it. What's your inspiration?
Yeah, thank you. Well, I think it started as a child. My father was a family physician, and I admired him greatly. And we would have dinner, and he would work in the evenings, 4 out of 5 days of the week, Saturday mornings, and he loved being a family physician and taking care of patients. And I went on to medical school, and then during my medical school years, I had mentors. And mentors, I think when you're younger, you don't even appreciate how powerful they can influence your career decision making and your life path. And I had really two wonderful mentors in medical school. One was the chairman of surgery, a renowned surgeon named David Sabiston. There's the textbook of surgery at Sabiston's, and
I met David. Amazing man.
amazing man. I mean, just, people say when someone walks into the room, he's in the room, and he was phenomenal for me. And then I also had the great privilege of working with Lowell King, who many would say was the father of modern pediatric urology. And he really developed my interest in research as a medical student. So that's where I became very fascinated by urologic surgery. I was actually on my way to doing cardiac surgery. So those are some of the key mentors for me, many others along the way, but including my chairman of urology at New York Hospital-Cornell, E. Darricott Vaughn. I had the privilege of working with many others along the way. So I'm, as I say, I stand on the shoulders of giants.
I think you know what kind of person you're going to be talking to when their narrative begins with that. And I think that we're very privileged in medicine in that this is a story oft told. Um, and I can think of a few other fields, and I just mentioned one in politics where people would be inspired by people who went before, and it wasn't about egotism and it wasn't about narcissism. Quite the opposite. It's about humility and trying to be the best you can be. Well, you've been pretty damn good, I have to say. And as I said, your CV is impressive. Multiple clinical trials, more than 350 papers. What do you consider some of the most significant advancements or findings from your work, and how have they impacted patient care today in urologic oncology? Perhaps what we might do is you could pick one from each of the areas that you're into: prostate, kidney, and bladder cancers.
Yeah. Well, it's been an incredible journey, and I think when I first began my career, we were, subsumed in this notion of nihilism, and we don't talk about that anymore as it relates to cancer patients, and that we had really an incredible lack of options for them. So many patients, for example, in prostate cancer, the vaunted work of Huggins and Hodges, of course, demonstrating that lowering testosterone was really the most important breakthrough 70 years ago in putting prostate cancer into remission. And that's how it was from 1944. Nobel Prize in 1966. When I finished my residency in 90, that's all we had. And it wasn't until 2004 that we had a chemotherapeutic advancement that improved survival. And fast forward from 2004 to 2024, 20 years later, in prostate cancer, we now have 12, arguably 14 FDA, EMA approved medications that are life prolonging in prostate cancer. And I think when I think about your question, for me, having had the opportunity to really be involved in all of those trials from early phase to late phase that led to the evidence for their regulatory approvals has been an enormous privilege. And then sort of semicolon to that, having the opportunity within community practice is really where I've focused my career, but creating a research center and to bridge tertiary academic centers with community for not just in, where I am, but all over the world, to say, look, we're all physician scientists. And we all need to always remember, yes, it's fantastic to take care of patients and their families, but we always have to be thinking about how we can change healthcare. And cancer care, along with cardiovascular issues, infectious disease issues, is really at the top of the list and how we can improve cancer care.
Absolutely. Trying to remember who it was who talked about the ward and the operating theatre being the best laboratory.
Yeah, that
Uh,
was Halstead.
William Halstead.
Awards are laboratories, laboratories of the highest order. I love
Yeah,
that quote. Fabulous.
there's
Yeah.
there's a book about his issues at it's called Genius on the Edge, and I hadn't known this, but he discovered developed the concept of local anesthesia, and in the process became a cocaine addict.
Yeah.
It's fascinating book, and very, very interesting to read about there's that word again, politics, at Hopkins back in the day.
Yeah.
When that hospital was founded, boy, as they brought along these titans to kick
Yeah.
it off.
No, you're right. I mean, Halstedian principles, O'Slarian, and interesting that you bring up cocaine. Arthur Conan Doyle, Freud, some of our greatest thinkers, had that in their background. I'm not endorsing that, but it is interesting how we evolve and we recognize how certain things which seem to be benign can end up being problematic.
Yeah, it's actually interesting because it's way the hell off topic here, but the emergence of the concept of attention deficit hyperactivity disorder as a disorder, rather than as I'd always thought of it, as there's a spectrum of behaviors. There's tall people, there's short people, there's outgoing people, there's reserved people. And now we're medicating it away. And I wonder where the next generation of Picassos and
Yeah.
Chagalls and Leonard Cohens are going to come from if we medicate people into this sort of platform. And if you've not read it, by the way, Aldous Huxley wrote two books, The Doors of Perception and Heaven and Hell, about his experiences
Yeah.
experimenting with mind altering
Oh,
drugs.
oh, yes, Doors of Perception, fabulous, and thus the inspiration for the Doors, the band. But also, you talk about mania, hypomania. Look at Handel's Messiah. I mean, he wrote it, I think, in like what less than 24 hours. It's just or some insane time frame. And you're right. I mean, there are some incredible artists and thinkers and discoverers. There's a great book. The name is escaping me, but it was written and it talks about the breakfast behavior of great thinkers and geniuses and what they did in the morning hours. And invariably, there's an incredible amount of mania, tobacco abuse, and alcohol abuse. And again, I'm not endorsing any of that. Of course, we now talk about and bringing it back to healthcare, how important exercise is and nutrition and avoidance of tobacco ingestion and alcohol avoidance or in moderation. But I think your point is extremely well taken. If we medicate away some of these really rather remarkable aspects of human personality, will we lose creative, innovative opportunities?
Well, let's bring it to surgery, to the way that you and I have spent our life. You in urology. My guess is, with the wealth of work that you've contributed, you are not cut from. There are many wonderful urologists out there who will go through their practice life looking after patients. They may never write a paper. They may never have an original thought. They may just be kind, hardworking, dedicated urologists. And they may also be the sort of people who will be very slow to take up new innovations because they don't have that gene, that hunger for new knowledge. Do you not think that people like you um, are cut from a slightly different cloth? You see the world through a different optic. I'm not suggesting you use mind-altering drugs, but your brain works differently.
Yeah, I appreciate the question. One of the things that really troubles me today is this explosion of the word or the phrase expression burnout. And it saddens me greatly. Then you hear this burnout. I'm sure it's in many fields, but it's very prevalent within healthcare.
Yes.
Physician burnout, nursing burnout, and it makes me so sad because to me the joy of getting back to being a physician, a healer, a Schweitzer, a Halstead, an Osler, um, all the great advances, but also just the privilege and the honor to take care of patients and to appreciate the science. I think that the profession of medicine is unbelievable, and it makes me terribly sad to hear about the burnout. Now, how do we how do we combat that? And there are a lot of different ways to combat that. Maybe it's our overly bureaucratic, regulated healthcare systems all over the world, not just unique to the U.S. And I think finding the joy in your life, finding that passion, which is clearly involved in all aspects of medicine, whether it's urology or any other field. And one of the things that I was acutely aware of was this sort of internecine warfare amongst specialties when I first began my training. Well, you can't do that because it's not within your purview. And I've come to realize early on, look, we just want to optimize care for patients. I don't care who's giving it, as long as it's someone who he or she is not a dabbler, but is truly dedicated and learned in what they're doing. And so we have to have certain guardrails to make sure that that's not abused. But the profession of medicine has just exploded in terms of the requirement for knowledge. And it's a bit hackneyed to say it, but it truly takes now this multidisciplinary team working together well. We have this expansion of an aging population. People call it the graying of the world or the silver tsunami. And we have a person power shortage of healthcare providers. So we all have to work better together and be inspired by all the learnings that are happening on a not even daily, hourly, the amount of knowledge that's pouring through our literature, both electronically and written, whether it's artificial intelligence or a new marker or a new device or a new therapeutic. And one of the things that really challenges me is, when you think about, you and I were talking earlier before about the political world and the challenges there. I'm a full-on globalist when it comes to healthcare. When you have cancer, I don't care what your passport says, what country you're in. You have cancer, you want to be treated. Your family wants you treated. We don't care about your politics or what your passport says, what country you're from. You've got, arguably, not always, but you have a life-threatening illness. How do we take care of that patient from a humanistic standpoint? And I think that's still, to me, one of the beauties of and the privilege of being in medicine.
100% with you. A guy named Hippocrates thought that was a pretty good idea a while back. You're absolutely right. And when I hear about, when I get together, you and I are the same age, when I get together with my cronies from medical school, many of whom are still very, very dedicated physicians, very, very involved in patient care, phoning each other or emailing, texting. I've just seen a patient with such and such, and this was going on. What do you think of that? Isn't that cool? Isn't that interesting? And other people have said, well, when are you going to retire? And my response would be, from what? I don't work. This isn't work. It is a joy and a privilege. And there's got to be something wrong with the way we're getting people into medicine today. And like I told you, I've been on both sides of the Atlantic, and I've operated all over the world. People are people. Doctors are doctors. I don't think we're recruiting the right kind of people into the profession, frankly, and I don't think we're giving them the right tools. You mentioned Osler. Sir William Osler said, I believe, in a lecture to young doctors about how to have a successful practice, you should be able, which is obvious. You should be available, which is also key. I can't see you for 4 weeks, BS, right? And his final one is affable. Able, available, and affable, right? I tell people I get to meet lovely new people and hopefully help them at a very tough part of their life. So let's get on to a specific, and I want to challenge you a wee bit. During your career, the treatment of kidney and bladder stones has gone from operations of Hippocratic relevance, who I've just mentioned, of course. Thou shalt not cut for the stone, but shall leave this for practitioners of that art. And I remember I was at Cedars-Sinai when the first Eswell machine, extracorporeal shockwave lithotripsy machine, was treated. And it was like that scene out of 2001: A Space Odyssey, where there's the black monolith and the apes are coming up and touching it, and they're kind of, what the hell is this? Are we scared of it? And like one guy says, hell no, because it changed percutaneous extractions to as well. There was this incredible and very rapid change from doing open lithotomy to endoscopic to percutaneous to endoscopic to as well, plus or minus stenting, of course. Can you please reflect on similar transitions that have or are still occurring in your specialty of urologic oncology?
Well, it's a great example. I do love that moment in 2001: A Space Odyssey. I mean, Kubrick, what a genius. And he probably, getting back to it, probably only maybe slept 4 hours a day. That might have been a good night's sleep for him. But wow, was he ahead of his time in that movie? And just that opening scene is just phenomenal. And you're absolutely right. I was there at when the ESWLs came over. Christian Chaussee, Germany, brought it over to the United States. We had five initially in the United States, and where I was at New York Hospital-Cornell was one of the five. And you would have thought that this was heretical, because we were still doing a lot of, open stone surgery. Gosh, we loved it. Ureterolithotomies and open nephrolithotomies and just wonderful surgical interventions. But I think
Very
the over
satisfying to do. I mean, I used to scrub into them as a resident. So satisfying. You make a hole, the patient's in pain, you make a hole, and you pull out, like Christopher Horner, you pull out a
yeah,
stone.
yeah,
Problem solved.
right. It's almost akin to like taking out the bullet and dropping it in the bucket, and
Yeah.
here you found it. Isn't this
Exactly.
wonderful? Look what we did. But I think it speaks to a larger notion around surgery. I mean, we as surgeons, regardless of your field, are dedicated to making our profession somewhat obsolete, and avoiding interventions because, this don't cut for stone. Yes, I mean, if we can avoid making any sort of an incision to fix, a leaky heart valve, or removal of a cancer, removal of an organ, extirpative procedures, whether they're done open with an incision, um, and as a great mentor of mine used to say, don't skimp on the length of the incision because they all heal side to side. But nonetheless, there is a morbidity to an incision, and there's a morbidity to anything invasive. So we're always thinking, okay, how can we advance technologies, devices, whether it's an extracorporeal shockwave lithotripsy, percutaneous procedures, radiation procedures, thermoablative procedures, and then targeted therapies, whether they're with small molecules or immunotherapies. So, how do we make it less invasive, less morbid, and of course, affordable and accessible?
Yeah. Yeah. Um, I think people might look askance to hear a physician say, I want to make myself irrelevant. But I think in my career in general surgery, the things that have changed, probably 30% of the work I did as a resident was looking after people with peptic ulcer disease. And, I ask a current surgical resident how to do a highly selective vagotomy, and they'll look at you like you've got horns. I mean, it's an infectious disease now. And isn't that great? So forgive me if this is old news, but the audience is, although our audience is largely healthcare practitioners from all specialties, we also get interested members of the lay public. And frankly, I think some physicians would be interested in this answer. What's the current guidance on the use of PSA to screen for prostate cancer? And I told you before we got going that in recent week or so, three of my friends have been diagnosed. So who should be getting it, when, how often, and how do we react to it?
Yeah, this is an area that you take a good biomarker, a blood test. We talk about biomarkers. They can be blood-based, urine-based, tissue-based, imaging biomarkers. And that's where the PSA, the prostate specific antigen unique to the prostate, it's not a perfect biomarker, but when used selectively and used judiciously, depending upon the age of the patient, family history, risk of cancer, important notion now, doing a good family history, not just of prostate cancer, but cancer in general, our ability to better understand genetic mutations, hereditary versus the genetic mutations within the tumor tissue itself, which we sometimes call somatic, but understanding hereditary issues, understanding the absolute PSA level for age, as well as PSA changes over time, which we call velocity or sometimes kinetics. there's an here's an overused term, but it's an important term, is we have to individualize to the patient. It's not a classic one size fits all. And I'll just continue to throw out, overused similes, but we don't want to throw the baby out with the bathwater. And that's pretty much what happened with early, well intended screening suggestions by varying agencies. Don't check it at all. And the problem with doing that, and I think part of that may have been, don't check the PSA, because urologists, my colleagues, were over responding. Too many biopsies and too many cases where we'd pick up indolent low grade cancer and overtreat. But prostate cancer, there's a spectrum. There's a percentage that's low grade, indolent. We don't even really ever need to know about it, but yet it's still a highly prevalent, leading cause, depending upon where you are in the world, cause of cancer mortality in men. So it comes down to, most importantly, better education and amongst physicians, and then this very important notion of shared decision making. We've moved away, in my mind, clearly, and I think most would agree, from being paternalistic physicians saying, I'm the doctor, you'll do this. And we have to be better at saying, look, here's why we don't need to get a PSA, 85-year-old man who's had a normal PSA for the last 20 years. We can stop getting that. Could have maybe stopped getting it earlier, as opposed to, hey, you haven't had a PSA in 20 years. You're in great health. Your parents lived into their 90s. That patient could also still get advanced prostate cancer. So we have to be thoughtful. We have to look at the patient's overall comorbidities, their health history, what their PSA history has been. PSA is an inexpensive test, but like with anything, there has to be a thoughtfulness and individualization for the patient. So I don't agree with not getting it. I agree with using it in a judicious manner.
I think you said it perfectly there. It is about the dialogue between the physician, the patient, and their loved ones. And I was told a long time ago that very often it's the female partner of the man that leads the decision-making process. And that takes me, I guess, onto another approach. Men aren't as good at getting their health checked. I write for an aviation magazine, have done for many years because I fly. And it's the one area where men are actually good at looking after their health, because if they have a health problem, they lose their medical. And if they lose their medical, they can't fly their airplane. And so they'll actually, it's a teachable moment, but on the whole, men aren't as good at getting health checks. They're not as good at advocating for their causes as women are. Women are much better organized. Yeah, we've had in prostate cancer Michael Milken with CapCure and so on. But what more can we do to drive investment? And I'm not just talking about financial investment, intellectual and emotional investment into men's health issues, and specifically men's cancers.
Well, I'm going to say something that may be overly controversial, but
Good.
there's no doubt that the phenotype, the female phenotype, is much more evolved than the male phenotype when it comes to advocacy and sensitivity. And we as a male population have a lot to learn from our female population. They've done incredible work in breast cancer. The Komen Society, and the women are clearly, as a generalization, they're more nurturing, they're more sensitive, and they're greater advocates for their causes. And we have a lot to learn from them, but we have done better. So Prostate Cancer Foundation, Michael Milken, other really important advocacy groups, Yomo, Prostate Cancer Foundation, as I said, Zero, FEN, Prostate Health Education Network, really doing wonderful work to get education out there for patients to understand that they need to push their physicians, whether it's in urology or anything else, to say, wait a minute, make sure you're explaining all of my options to me. And if you don't have those options, then maybe I need to go elsewhere. And that's really to be, as they say, an educated consumer is your best customer, and
Yeah.
not dissuade people from getting second and third opinions, which I think is very important. Yes, I we lament social media, but one of the really great things about the internet is the giving the democratization of access to folks regarding, hey, I've just been given a diagnosis. I've got gallbladder stones. Do I need my gallbladder out? Well, I can just Google gallbladder stones, or I can Google prostate cancer. And what is my stage? And how do I think about this? So I think that's actually been a tremendous advantage to helping that educational initiative. As we were saying before, there are some differences, ethnographically, racially, potentially hereditary, but by and large, the options available for patients, the accessibility, the notion about clinical trials, super important for patients to be knowledgeable about in their decision making. And they can get this information by just doing a little bit of interrogation on the internet.
Yeah. I've actually publicly talked about exercising caution in using Dr. Google. And yes, it can be useful to find such assets, but it can take people down a very.
You're absolutely right. And you have to be discerning about it. And I don't know that I have the best answer for that. I tend to give my patients trusted websites, and I never my own. I never, because that's somewhat self-promoting. I tell them to go to Prostate Cancer Foundation. I tell them to go to nonprofit advocacy groups, Maple Tree Cancer Alliance, Ask American Society of Clinical Oncology, European Society of Medical Oncology. Go there. Don't go to Neal Shore, XYZ, buy my product. I've never done that. And I think that is an important lesson for patients.
I'm a mad keen football supporter. The kind where we use our feet and a ball. Um, and a lot of my contemporaries are dealing with prostate cancer, and we've lost a couple in recent times. Some lovely men, and they were all involved in an advocacy organization. But critically importantly, there were medical voices and the celebrity voices. And, men, we do tend to mirror our heroes. And I'm a big believer that celebrity voices, properly curated, can be a very, very powerful way to drive advocacy. I met Milken years ago, and together with a guy who I worked with at Cedars, a chap named Skip Holden, and who you may know. And I was impressed with Milken. He was a force of nature. And, he was saying, we're going to beat prostate cancer. And once we've beaten prostate cancer, we're going to take on all the other cancers. It's just a matter of money, which I thought was, sadly a little naive, but my goodness, you've got to give the guy kudos for doing what he's done. So, staying with prostate cancer, and it's an area I've been interested throughout my career. The advent of the robot has revolutionized the approach to prostate cancer. And you've already, I think I know how you'll approach this, but if you're a hammer, the whole world looks like a nail. In other words, is it overused?
Yes, we use that expression. If my primary tool is a hammer, then everything looks like a nail, and that can be said about surgeons and radiation therapists or clinical oncologists in the UK. Or if you're a systemicist, then everything should benefit from my use of a systemic parenteral therapy. And I think that's where we have to have guardrails around the what's in the interest of optimizing patient care. A lot of the different models in the world are volume based as opposed to value based, and we talk endlessly about that notion about value based healthcare, which I think is incredibly important. But healthcare delivery, regardless of your specialty, has so many different components to it, and it influences political, medical, legal. But I think it's, in my mind, and I'm very biased by this because I'm a physician, I think the physicians have been, in some situations, marginalized on making those decisions. And I think it'll be very important for global healthcare to get more of a physician say, a multidisciplinary physician involvement to say, this robotic approach is perfect. No, at this moment, it's overutilized. No, at this moment, it's not clear. And I think that because of the complexity of healthcare and the extreme increase in the costs of healthcare, which disadvantages many of our colleagues and friends and patients in the developing world, we have to become better stewards of this. The recent Lancet Commission, one of the key chairs was a good friend and colleague of mine, Nick James, who's in the UK, is really addressing these issues. So you take something such as the robot, which is a very expensive piece of machinery, it has to be used judiciously and efficiently. And I think we still, that's one of the big challenges in front of us in healthcare.
Absolutely. And again, it comes down to your earlier point about a dialogue between, and a friend of mine, I shan't mention the center, a friend of mine who was diagnosed with what looked like, to me, a very indolent tumor, was told that he needed a radical, and was told that the incidence of, he's an active chap and he was diagnosed at 51, I think, that, there was no issues with incontinence. There was no danger of impotence. And I'm like, I can hear klaxon warning horns in the background. That's any surgical procedure, any operation, any drug that doesn't have side effects. You've got to wonder about the veracity of what you're being told. So switching therapies a little bit, there's been some excitement about the potential for targeted alpha therapy, or TAT, unfortunate acronym, combining a drug conjugate with actinium-225 for prostate cancer. And I saw some recent work in men, I think it was ASCO, it was presented in castration-resistant disease, getting impressive results, not without side effects, but these are very ill pre-terminal men, effectively, but impressive results nonetheless. What are your thoughts about this modality and the promise it might hold?
Well, I'll just tell you, it's incredibly exciting. But before I answer that, I love, we love acronyms in medicine, don't we? So TAT, targeted alpha therapy, but another acronym for TAT is turnaround time. So when we order a test, we want to
Yeah,
get that test back quickly, right? I mean,
yeah,
gosh, in the U.S., I have a very demanding American population. What do you mean it's going to take 2 weeks? I want to know my results
on it now.
tomorrow. Can't you call me later tonight to make the decision? So TAT, turnaround time, we talk about that a lot in terms of testing, but
Yeah,
it also can be used, as you say, for targeted alpha therapy. We also have other targeted beta therapies. We've had radiopharmaceuticals for several decades. The earlier gamma beta particles were very toxic. Now, that's old school. The newer beta particles, starting with actually an alpha particle starting with radium 223. And I was very honored to be able to give the actual first dose of radium 223 in the United States anywhere post FDA approval. And so that was over 10 years ago now, but we have that approval of radium 223. We now also have another beta particle known as lutetium 617, which has been approved for men with advanced stage prostate cancer, as has radium. And now we have the alpha particle. So the difference between betas and alphas is size, and how it impacts and creates a cell kill, or what we say apoptotic effect. You're absolutely right. There are different side effects. And any physician who doesn't discuss side effects is doing a disservice to his or her patient. That said, the radiopharmaceuticals are clearly revolutionary in terms of augmenting our existing novel mechanisms of action, whether they're chemotherapeutics or immuno-oncologics or targeted therapies. So this is really a wonderful now opportunity to give additional tools to our armamentarium or weaponry in our armamentarium or our toolbox, and again allow for a multidisciplinary team approach, because to deliver radiopharmaceuticals takes certain licensure and ability to administer these therapies. But of course, it also, these are expensive. And one of the things that as I enter this portion of my career, is how do we figure out, do the trials, show the level 1 evidence that actinium, and undoubtedly it will. And these trials are going on. I love it because it's so exciting to do these trials, not just in the most advanced patients who are closing in their timeline to death, but that's typically how we do the trials. We take the sickest patients first, show that there's efficacy, and then say, okay, now that we see that there's efficacy, how do we migrate it more proximally in cancer stages, or what people oftentimes call the journey? Um, so yes, it's a wonderful radiopharmaceuticals, alpha particles, beta particles. There's a whole list of other molecules, tracers that will be coming forward in addition to actinium. This is a very important moment in a therapeutic discovery.
Yeah, so my understanding of targeted alpha therapy is that these particles have a very short, they can travel a short distance, but when they hit a cell, they hit it with a lot of force. And fingers crossed that we can help a lot of people as these things mature. I'd like to ask you about, given your publishing experience, both as an author and editorial, what do you think are the 3 advances, or an advance in prostate, bladder, and renal cancer that have you excited? Things that are on the horizon or just over the horizon. It doesn't have to be all 3; it could just be one. What's got you excited?
Well, yeah, I'm focused in GU oncology, prostate, bladder, and kidney. I think in prostate, bladder, and kidney, we one, you know, con, a theme across all is, look, patients with advanced disease outside the primary organ, the prostate, the bladder, the kidney. It's fairly uncommon for us to say, we can cure you. And that is still the hope, that patients with advanced or metastatic disease, we want to be able to say, we have a high likelihood of cure, and where the cure will not be overcome by the toxicity. I talk to patients about 4Ps who have advanced disease, prolonging survival, preventing complication of therapy, preserving quality of life, and then preference value. Are you risk averse? Are you risk seeking? In prostate cancer and in advanced bladder and kidney, it's still life threatening. That said, we have so many new therapies. I mentioned earlier 12 to 14 in prostate cancer. There's now 7 to 10 in bladder, 8 to 12 in kidney cancer. So it's been a great privilege of mine to have been involved in these therapies that have reached approval, access to patients, and we have to administer them, and we still struggle with the ideal sequence. We still debate. I've been privileged to be part of the Advanced Prostate Cancer Consensus Conference. It meets every 2 years in Switzerland, started by wonderful colleagues of mine, Silke Gillison and Aurelius Omelin. It's
Actually did a webinar with Silky.
She's phenomenal. I mean,
Force of nature, astonishing.
She's a force of nature, and we try to debate and answer unmet needs. And so, getting back to the beginning of our conversation, why would anybody be burned out in healthcare when there are all these unmet needs that we still need to be striving for? I'm not trying to invent a better smartphone. I'm not trying to invent a better computer. I'm trying to, help patients live longer with quality of life and not die of cancer. That was really the hope, that we can have our patients ultimately succumb to old age, which is a euphemism for a cardiovascular event. We're, as oncologists, we're in competition with our our cardiology colleagues.
Who can stop them getting to the funeral home first? That's absolutely right. So I think much of what you've said sort of sets up this penultimate question. In addition to your professional achievements, I ask people, tell me about something about you that's got nothing to do with healthcare. And you said you're inspired by kindness, beauty, and truth. And the kindness and the truth, I think, have come over very clearly and I'm 100% with you. This is what a privileged way to spend a life, right? Looking after people at the most grim parts of their life. Actually, I'll set you up. So kindness, beauty, and truth. I want to know how they shape your approach to patient care. One of my buddies who I went to med school with, so we've only known each other since we were 17 years old, and we still talk pretty much every single day. He's a general practitioner, and he tells new patients, that he has three things underneath his desk. He says, I have a checkbook, a magic wand, and a gun. Which do you need? And he says, astonishingly, in over 40 years of practice, no one has ever asked him for the checkbook. But, he talks about being there. And, he's told me over the years of patients, marriages that he's gone to, and children have been born in his practice. He's gone to funerals, and he's very much felt a part of being like your father, a family physician. So beauty, kindness, truth. Tell us about those.
Well, you answered it. That is the beauty of being a physician, or anyone in healthcare, is the daily interaction when somebody comes in and they bring you vegetables from their garden to explain to you how meaningful their interaction was, or they come to the appointment and the day before their beloved pet had died, or that a child had succumbed to suicide, or a malignancy, or a motor vehicle accident, and they share that moment. That is the beauty and the motivation on a level within the clinic. But the other beauty that I think is just spectacular is seeing somebody who's a true research scientist. Not me. I do transformational clinic things. But my colleagues who are really, the basic scientists who discover the way proteins work better with certain imaging modalities, or a new molecule or a new target, and how we can leverage or exploit that to help patients. There's an incredible beauty within that. Truth right now is a scary commodity. As we said, Dr. Google is not the answer. So I think that's really important. You brought that up. But we with the pandemic, people started saying, well, wait a minute, I can't trust science anymore. And I don't know that I'm going to trust, some news media outlet of a person who has no scientific credibility, but just is very vociferous. And so I really worry about where people are now getting their notion of truth. And then kindness, we live in a world that's filled with a lot of political vitriol, wars, and partisanship. And I think, where is the kindness? And I think physicians, if we learned anything by taking that oath of Hippocrates, is about kindness. And so I think, and by the way, that those three things, that I didn't think of it originally. It's actually Einstein. That was when he was, that was one of his motivating things. And so I'm violating his copyright. So I think that I hope that anyone listening today, and if they have a child thinking about a career, medicine is still a wonderful, wonderful career. And if we can help create a healthier planet in many different ways, there's a lot of different aspects to a healthier planet, but taking care of patients' health needs is always going to be vital.
Yeah. And what I tell people when they tell me that I've been mentoring a friend of mine's daughter at the moment, who's clearly a very brilliant young woman, and she has all these concerns about this. She's heard about healthcare and that. And I said, so be the mistress of your own destiny. Be the kind of doctor you want to be, not the kind of doctor that the media tells you. You know, she said that she would have an ethical problem with going on strike. She said, I just can't understand how that's, compatible with this kind of career. How can you take an oath and then breach it for personal interest? So I think we could talk about that for ages. So I'm going to give you the opportunity to wax lyrical. You come across a magical genie. You have 3 wishes for your area of healthcare. Have at it.
Well, I think that I would love to see a greater use of multidisciplinary teams across the globe, and to move away from siloing of, hey, this is what I do. I've got my hammer, or I don't have someone else's hammer. So, in addition to a multidisciplinary approach, I want to expand accessibility. That would be number 2. And I think that rather than us continuing to think about, building up weapon systems all over the world, let's think about how we can enhance accessibility to quality healthcare. At the end of the day, I think most people, if not all, they wake up and they think, we want shelter, we want food, we want to be good to our loved ones, and we want education. So, but it stops abruptly if we don't have quality healthcare. And then maybe the third thing would be to continue to make sure that our colleagues, the next generation, the current generation, understand the wonderment of medicine. And I like the word wonderment because you see it in art, and you see it when you just maybe see a 5 or 6 year old child look into a dense woods, who thinks, what could possibly be in there? And I think that maintaining wonderment about healthcare and advances will help avoid this worry about burnout, and worry about strikes. I understand your friend's concern about that. I don't want to be, I want to be knowledgeable and say, look, we also do live in a world where people have to take care of their families and feel that they're getting their rightful compensation for what they're doing. And that's an evolving process.
Yeah, truly. Well, just like everything else you said, it all makes perfect sense. Sadly, that's all we've got time for today. I want to thank you, Dr. Neal Shore, for taking the time to be with us. You're obviously such a very busy gentleman, but also for everything you've done for patients, everything you're doing for patients. And I think you talked about having role models at medical school and throughout your residency. I think anyone listening in who's looking for a role model to build their career on, you're it. Thank you very much.
Thank you very much. It's been a great pleasure. Look forward to working with you in the future.
Absolutely. I shall plan on a visit the next time I'm stateside. So, folks, I hope you've enjoyed this. Please, if you have, please subscribe. I believe we're available on Spotify and Apple Podcasts and all sorts of other technical platforms. And that way you'll never miss an episode. Check out the archives. There's loads of fascinating people on there. And hopefully I do very little talking and just bring you wonderful guests. Like us on social media, tell your colleagues, and please join us next week for another fascinating episode. Until then, I'm Dr. Jonathan Sakya. Thank you for being here at the EMJ Health Podcast. Please, everyone, stay safe, stay well, stay curious. Bye for now.